So I'm excited for our talk this afternoon that I have the honor of sharing with you as well, along with my friend and colleague, Mary Dunn, to talk about the tailoring care for the evolving needs of cancer survivors. So here is Mary's bio. And Mary Dunn is the director of the UNC Testicular Cancer Survivorship Program, and she works on several survivorship-focused committees throughout the cancer hospital. She helped to establish and continues to co-direct the UNC VHL Clinical Care Center. And Mary was awarded the 2022 APP of the Year by the American Urological Association. Congrats, Mary.
Thank you.
And she is also a founding member and the current president of the North Carolina Triangle chapter of the Bladder Cancer Advocacy Network. So thank you, Mary, for being here.
Thanks for having me.
As Mary's co-speaker, some of my background: I've been an oncology nurse practitioner for over 25 years, with the last 17 here at UNC. I am also a clinical assistant professor at the UNC School of Nursing. I received my master's from Columbia University and my doctorate of nursing practice here at UNC. And in collaboration with this amazing team, I've created and coordinated this webinar series for our advanced practice provider. Here is a sample of Poll Everywhere questions, what it will look like. As a reminder, join via the web or from the app on your phone. Go to pollev.com and enter UNC LCN. Here are our disclosures. So let's test our poll everywhere so you can respond at this time. A person is considered a cancer survivor from the time of diagnosis through the balance of life. There are many types of survivors, including those living with cancer and those free of cancer. True or false? I will give others an extra moment to get set up. How'd they do, Mary?
Pretty sure we've got some very intelligent people joining us this afternoon.
So thank you for participating, and we have more at the end, and we will, as a reminder, this is also how you will be able to submit questions to us at the end of the webinar. So today, Mary and I wanted to take the time to talk with you all about cancer survivorship, but also the tailoring care of the evolving needs of our cancer survivors, which I think has changed through the years. Our objectives this afternoon, we will discuss and describe the complex needs throughout cancer survivorship and identify key strategies for tailoring cancer survivorship care to address individual patient needs. And then we'll discuss the role of interdisciplinary collaboration and patient-centered care in providing comprehensive support services for cancer survivors throughout their lifespan. And here to start us off, again, which of the following is not a key strategy for tailoring cancer survivorship care to address individual patient needs? A, identifying and addressing the patient's physical, emotional, and social needs. B, providing patient-centered care that considers the patient's preferences, values, and goals. C, implementing standardized one-size-fits-all treatment plans for all cancer survivors. Or D, fostering interdisciplinary collaboration among healthcare providers to ensure comprehensive care. I will give you a couple of seconds. So Yes, you're correct. And this might have been a softball question, but the point of having a question like this was really to hit home that even everything we talk about today is not going to be the one size fits all for even a similar patient case scenario. So important to understand these evolving needs. So thank you for participating, and I will pass it over to Mary.
Awesome. Thanks, Tammy, and thanks everyone who is joining us this afternoon. Your responses to our questions thus far just show that you all are very interested in survivorship and already have a pretty solid foundation. So we're hoping that you'll take away some points from our session this afternoon and look forward to sharing them with you. So the first few slides I'm going to go through are some really what I consider staggering numbers in the world of cancer survivorship. So we're going to start by sharing these numbers to help set the stage for why talking about the evolving needs of cancer survivors is going to be so crucial. So these graphs and numbers are to help demonstrate the vast changes that have happened and will continue to happen as our patient population ages and more people are living with and or have survived a cancer diagnosis. So if you look at this graph here, it starts at 1975 and all the way up to the year 2040, how those numbers have changed and will continue to change. So by the year 2040, there will be 26 million cancer survivors. This will have significant impacts on how we as APPs and our fellow oncology providers deliver care, who will be delivering this care, access to survivorship care, and the quality of care that we deliver. So just a staggering number. Again, with the numbers, another incredible number. There's 16.3 million survivors are living 5 or more years after their diagnosis. And even more promising data that will help continue to shape the future of survivorship care. So 69% of survivors have lived 5 years since their diagnosis, 47% longer than 10 plus years, and 18% 20 plus years. And to highlight that there are a large number of survivors living with metastatic disease, which is also expected to increase. And I may touch on this in a later slide. I can't quite recall, but I think sometimes folks who are living with advanced or metastatic cancers don't often get talked about enough in the survivorship space. And I think we need to do a more comprehensive job of making sure we're talking about their unique needs in the context of what it means to be a cancer survivor. So not unexpectedly, our cancer survivors are also getting older as our older generations get older. So 67% of survivors are greater than 65, and this number is just going to continue to grow over the years. So we know that folks who are older have more unique needs, so different needs than our patients who are younger. So having to tailor our care to meet those needs is going to be crucial. Just to highlight that compared to other members of other races, Black and African American people have higher rates of being diagnosed with and dying from many different kinds of cancers. And this slide here breaks down the estimated number of cancer survivors by cancer type. And this is data from a couple years ago. Of course, the most common types of cancer represent the highest number of survivors. So what is survivorship? There are many definitions, several of which are widely accepted. It includes patients with cancer from the time of their diagnosis throughout the course of their life. And newer definitions of cancer survivorship also rightly recognizes the caregivers in people's lives. This looks different for everyone, and not everyone who has a cancer diagnosis or a cancer experience actually identifies with the word survivor. It's just kind of the broadest term that we use in this context. So 4 main features of survivorship care that we're going to touch on are surveillance and prevention of recurrence, surveillance of medical or psychological effects of cancer. I'm going to touch on these 2 components. And then also intervention for late-term and long-term effects from cancer and cancer treatment. and health promotion and quality of life, which Tammy will touch on those. I love this. I absolutely love this this visual of phases of cancer survivorship, because I find it to be one of the most inclusive visuals that I've found so far. And it goes through the definition that I think really encompasses what a cancer survivor is. So an individual is considered a cancer survivor from the time of diagnosis through the balance of their life. And there are many types of survivors, including those living with cancer and those who have been cured or free of cancer or are considered to be in remission. Oftentimes, like I mentioned, we think about survivorship in the context of people who are being treated with curative intent, or folks who are done with treatment and are doing post-treatment surveillance and survivorship visits. But a more balanced way of looking at survivorship includes all patients through the balance of life and at any stage. So this is why I'm a big fan of this graph here. So this is a patient example of an older woman, so nearly 80 years old. She has a few comorbidities, and she was diagnosed with stage 3A adenocarcinoma of the colon. Unfortunately, following a delayed diagnosis during the COVID pandemic. She had a partial colectomy and then adjuvant chemotherapy for 6 months. Caveat, I'm urologic oncology, so any questions about GI oncology, please punt those over to Tammy. So let's take a look at surveillance and prevention of recurrence. And we think about what are the best ways to surveil patients after they've completed their treatment for curative intent. There are numerous guidelines from different societies that help us come up with tailored surveillance plans for patients once their definitive treatment is complete. There are disease-specific follow-up pathways, many of which I'm sure you are familiar with. A lot of us use the NCCN guidelines that are easily accessible. But here you'll see there's also survivorship-focused guidelines. They discuss things like physical activity and cancer testing, so making sure people are being screened for other cancers that are relevant to their age group, of course. How to manage different side effects, particularly long-term side effect management from cancer treatment, whether that's surgical or systemic treatment or radiation therapy side effects, and then different assessment tools that we can use in the survivorship space. So in addition to those, how often do we see people and what diagnostics are we doing after treatment is finished? These are really nice survivorship guidelines to help integrate into your practice. So I would encourage you to take a look at one or two of these and see if it can help you guide your surveillance visits, maybe in a different and possibly more comprehensive manner. All right, so for our patient with stage 3 colon cancer, the NCCN guidelines are pretty easy to follow up with regards to clinic visits and labs and imaging studies, colonoscopies, etc. This type of information can also be transferred into a survivorship care plan. So I'm not sure how many of you are utilizing survivorship care plans into your practice, but it really is a nice, clean space to incorporate your patients' follow-up guidelines, because they're confusing enough to some of us. They can be very confusing to patients depending on their cancer type. How often do I have to have scans? Do I have to have a scope of something and labs, et cetera, et cetera? So again, some more guidelines. Sometimes we can find it hard to stop doing what is comfortable in the early years of post-treatment surveillance, right? A lot of guidelines have these arbitrary, after 5 years, it's kind of like, well, yeah, do what you think you need to do. It's very open-ended, and after that kind of arbitrary 5 years or 10 years for some cancers, depending on the cancer, it can feel a little bit scary for patients to stop doing routine surveillance visits and incorporating things that are comfortable for them. So, in my world, for example, PSA, right, for men who've had a prostate cancer experience. But when we look at guidelines, and again, this is Tammy's area of expertise, but beyond 5 years post-treatment for our colon cancer patients, they're not recommending this CEA, right? So that can be like almost feeling like we're removing a security blanket from folks. And I think it's important that we do a good job of explaining to patients up front what their surveillance is going to look like, so that when we get to these points where we might be stopping certain things that they've been used to having, that it doesn't come as a complete and total shock. So surveillance of medical and psychological effects of cancer is a hugely important topic. In fact, we could likely do a presentation on each one of these bullet points that could likely each be an hour. I have a lot of passion about this, but I also have a timer and someone to poke me for when I start going over my time. But just wanted to share a few of these with you. As you all know, there are a multitude of effects that can linger from cancer itself and the cancer treatment. Some are acute, some are more chronic in nature, and some are late term. This varies widely, again, depending on the cancer and cancer treatment and the individual patient characteristics. So, for example, what pre-existing comorbidities do they bring with them into their cancer experience that might exacerbate some of these things? These are just a sample of some of the most commonly reported effects among cancer survivors, many of which I'm sure sound very familiar to you. We know the number one thing that folks report is fatigue. We know the best thing to help with fatigue is exercise. And I also know that when we're telling people who are fatigued and dragging that what's going to help them most is to get up and exercise, they tend to look at me like I have 12 spinning heads, because it seems counterintuitive, right? You're tired, get up and exercise. But we know that's where the data lie. The psychological well-being of patients with a cancer experience is one of the most important topics to address. We don't always do a great job recognizing this. There are many barriers here, right? No one's at fault. We don't often have comprehensive training about how best to address the psychological and emotional needs of our cancer patients. Time is always a barrier. We could all use 1-hour visits for our patients, but unfortunately that's just not feasible. And then when we're doing things like distress screening, what is the pathway there? So, for example, who is doing that? Where does that data get stored in the medical record, and who is responsible for addressing that? So pathways are really important here as well. And then some patient barriers. So sometimes folks just don't want to bring this up with their providers. They're not sure how to bring up things like anxiety, depression, or distress. And there is still, in certain circles, a stigma around talking about psychological and mental health. Some people might be reluctant to try medical management, therapy, and or integrative medicine. So I think that systems need to do a better job with distress screening. You know, what tools are we using? Who are we using them with? Frequency, how often? Because early recognition of our patients, any kind of psychological distress, the support that we can provide them, validating their feelings, and making sure we can get them the help that we need. I often tell my patients, I will be the expert in managing your cancer care, and I have wonderful colleagues who are experts in managing the psychological aspects when it gets to be something that I'm not comfortable with, and we have a wonderful support team here at UNC. So in talking about cancer-related anxiety, it's important to not ignore fears. It's important to recognize emotions. It's important reminders to our patients to let them know that they are being heard, that we're truly listening to them, asking them questions about their emotional well-being during their surveillance visits, and letting them know that you see them as a whole person and not just their cancer diagnosis that's on the piece of paper. And like I mentioned, that even though if you're not the expert in helping manage these, that you are in fact listening to them and can get them to the right place. I think it's important that we give people permission to feel how they need to feel. We know that being a human being is complicated and complex, and then adding a cancer diagnosis and treatment on top of that just can make it even more overwhelming. Data also show that naming the feeling can actually help us cope with it better. So helping folks name what they're feeling. And then touching on very briefly just this concept of grief that I think is intertwined with going through a cancer experience at any stage, at any phase. We know that grief is anguish that is experienced after a significant loss. And with a cancer diagnosis, there are tangible things that folks grieve. So like the loss of their hair or the loss of their bladder, but there's also the intangible things that they grieve. For example, the loss potentially of relationships, or the loss of hope, or the loss of the future that they once thought they were going to have. So this topic of grief, I think, is something that we will be learning more about in the context of cancer survivorship as more studies are being done. All right, I think I'm handing it over to Tammy. Thanks, Tammy.
Thank you, Mary. And I think Mary brings up really important aspects that many times patients may not divulge this information to you about their fears or anxiety. And for the case example that Mary shared, where a person goes through their cancer treatment with curative intent, that fear of recurrence is sometimes numbing for people. So bringing up topics, exploring, having those conversations with patients to help them be able to talk about it and even identify it and know that it's a safe space that you can start addressing them. Because a lot of those anxiety can actually turn into, physical symptoms as well. So I encourage those conversations. So I will continue talking about these late and long-term effects of cancer and treatment and those interventions that we have. It is impossible to go through all of them. They could each be a talk in and of themselves. But Mary and I hope that we're giving you resources and places to go, and also thinking about your multidisciplinary team to help with some of these aspects. NCCN guidelines have not only the resources to tell you what test needs to be done at what interval, but also how to manage some of these psychosocial and physical problems. So, for example, the anxiety, depression, trauma, and distress it recommends distress screening or trauma screening, and then what those appropriate referrals are, and even some medication management recommendations as well, and including cognitive functions. Some point neuropsychological testing may be recommended. So I encourage you to go read those and explore those. We will take fatigue and dive a little bit deeper into that and some interventions for fatigue, as this is one of the most common distressing symptoms for cancer survivorship across the journey of cancer care. So to talk about these other aspects of survivorship, remember, this is not just those that get a cancer treatment. For curative intent, the landscape of oncology has drastically changed through the years. So to set this conversation up, I share with you this 73-year-old male who has a long list of comorbidities, including type 2 diabetes, AFib, hypothyroidism, CHF, and chronic kidney disease. He initially presented in 2010 with appetite and weight loss. He underwent a colonoscopy. And at his initial diagnosis, he was diagnosed with a stage 4 or metastatic colon cancer that had spread to his liver. Throughout the course of his 14-year treatment history with a metastatic colon cancer, he went through multiple lines of systemic therapy, including chemotherapy, multiple surgeries, and even some cancer-directed therapies and radiation. So I highlight this case, and we will continue to talk through the points of what this case is talking about, that not only the symptoms that he experienced from his cancer itself, but also his other chronic comorbidities that also play a role in his care. Which brings us to our next poll everywhere question. So chronic disease management before and during cancer treatment may improve cancer outcomes. True or false? we'll give you a couple of seconds. Yes, I acknowledge this may be another softball question, but I want to hit this message home to all of you that chronic disease management before and during after a cancer treatment improves cancer outcomes in many ways. So this article in the ASCO Daily News by Dr. Sam Seiker, who is here at UNC, discusses the importance of chronic disease management before and during cancer treatment. It not only improves cancer outcomes, it can lower all-cause mortality. So those diagnosed with a chronic illness oftentimes don't receive standard cancer treatments as those who may not have chronic illnesses. That includes chemotherapy, radiation, or surgery. So somebody's comorbidities may put them at a higher risk for surgical morbidity. So even if they had a surgically resectable cancer, that may not be an option because of their comorbidities. Or some of these other treatments. There are some cancer treatments that, kidney disease may impact the ability for a person to get a particular type of chemotherapy. And also with comorbidities that are not well managed, a patient getting a cancer treatment may not be able to complete their recommended treatment course. So in the curative intent, somebody may be recommended to get 12 cycles of chemotherapy. And if they have other comorbidities that are not well managed, it may limit their ability to tolerate that treatment course and could have an impact on their cancer outcomes. So in that article is this chart, which, again, hitting home the importance of this chronic disease management throughout cancer treatments and survivorship. That's whether somebody is being treated with curative intent or the long-term, chronic management of cancer, like this case I spoke about. He developed some of those chronic illnesses throughout his cancer journey. He had a cardiologist, he had an endocrinologist, he had a primary care provider, as well as his medical oncology team, that we all work together to manage all of these chronic illnesses. And I can't help but think that this is a prime example of how, when we can maintain some of these possibly morbid conditions, that somebody's life can be extended with proper management and coordination of care, hence really highlighting the importance of interdisciplinary care and calling all your specialists. And even in that final block, talking about cardiovascular risks, so understanding that and addressing that. And many times I have patients that are sitting in the room with me that are like, well, you're my primary care. I see you often enough. I don't need a primary care provider. I am the first to advise them on why they don't want me to be their primary care provider and the importance of having that overarching healthcare maintenance provider and how we all work together to optimize someone's care. So as you can imagine, this gentleman did have quite a bit of fatigue throughout his journey. And again, as I mentioned earlier, fatigue being one of the most common and most distressing symptoms, fatigue is persistent. It's also subjective, so it's hard to measure, or even as a provider, sometimes you can tell someone's fatigued when they're in the room with you, but there's not a lot of objective findings when it comes to fatigue. It's a physical, emotional, and or cognitive tiredness, exhaustion that is related to cancer treatment, or maybe another comorbidity, and is not proportional to recent activity and interferes with usual functioning. So fatigue doesn't stop when treatment stops. For curative intent, patients, I discuss with them, that's probably the symptom that lingers the longest, and gaining that endurance and stamina probably takes the longest to recover. So the prevalence is high. Almost 50% of cancer survivors experience fatigue, short and long term, and up to 85% on active treatment. I think those numbers are probably low. Fatigue is underreported, underdiagnosed, and undertreated. And 80% felt something could not be done. So again, another symptom that there may be many patients that aren't describing this to you, or they may be underestimating it because they don't want you to adjust their treatment plan if they complain about a symptom. So I spend a good bit of time discussing with my patients, how do you spend your day? What are your hobbies? Are you on the couch all day? Are you in bed all day? You have to ask these questions in many different ways. You can't just say, do you have fatigue? Are you tired? Because the more you explore with patients, you can actually find out a whole lot more about how they're spending their day. So what can we do about it? There is not a patient that comes in contact with me that I do not discuss physical activity with them. So, and you'd be surprised, many patients may feel that exercise isn't safe or it won't be helpful, but it is. And even discussing this with family members or caregivers to help them understand that exercise, getting up and being active is actually beneficial. I'm sure you have, just like many family members I don't want them to do anything. I want them to rest. I cater to them because I want them to, feel good and be able to tolerate their treatment and just focus on their treatment. But that's actually doing a disservice. So physical activity can improve quality of life, can help cope with side effects of treatment, and play a role in decreasing the risk of new cancers in the future and possibly risk of recurrence. The most important thing I describe to my patients is avoiding inactivity. As Mary referenced earlier, patients may look at me like I'm crazy to tell them to be active or go for a walk with maybe the level of fatigue that they're experiencing. But I ask them to find a balance on the days that they feel better to get up and do that walk, whether it's to the mailbox or whether it's in their living room or circling the dining room table. So any activity counts, and encouraging those steps, and the more they do, they can build upon that goal. So the American Cancer Society has this resource on their website for your patients to help describe to them the benefits of exercise before, during, and after treatment. The list is long, and we will go through a few more of these symptoms and the recommendations of where physical activity can be more helpful. So here are some resources for you and your patients. So many patients will approach physical activity differently. Some may benefit more from being in a group and attending programs like the Live Strong program at the YMCA and having that peer support. Others want nothing to do with it, or they may have a diagnosis that being in a group setting like that may not be safe for them, say if they are neutropenic. And there are apps that help guide patients at home with safe activities specifically designed for people who have a cancer diagnosis. So I encourage you to share these with your patients. So here is what I was referencing earlier about the effects of exercise on health-related outcomes in those with cancer. So the first one in this chart is cancer-related fatigue. And there's actually a dose to benefit. I have some patients who will say, well, I walk at work, or I'll walk when I go to the grocery store, which counts, right? Because any movement counts. But I try to take it a step further with my patients and talk about the benefit of activity when you're getting your heart rate up and more of that sustained time of being active. And again, that may just be for 5-10 minutes at a time, but encouraging them to try to build that up. I have seen it in my practice that those who are more active, engaged in physical activity, getting their heart rate up, they feel better. Fatigue is not as profound. Some other areas of the benefits of physical exercise, quality of life, overall physical function, mood and the psychological effects of cancer, anxiety and depression, and for some lymphedema if they have had a treatment that impacts their arms or legs. So again, these are dose recommended, and I think it's important for patients to understand that. It doesn't mean everybody is going to meet those recommendations. Also of note, there's moderate evidence to say that exercise improves bone health and sleep in cancer-related or health-related outcomes, but we know it can't hurt. So again, encouraging movement. So that scenario talked about comorbidities and the long-term disease management of somebody with a metastatic cancer, and many people are living longer and are considered survivors, and those survivorship aspects and interventions and conversations still need to happen. The other area where this is really important and has changed this concept of survivorship is the role of immunotherapy. And this case scenario sets that up for us. So this is a 73-year-old gentleman who has a past medical history of hepatitis C, which was treated and cured. And he was initially diagnosed with a hepatocellular carcinoma or a primary liver cancer back in 2015 and actually had surgical resection. Unfortunately, 2 years later, he did have recurrence of his hepatocellular carcinoma, and it had spread to his bone, so he had a stage 4 or a metastatic liver cancer. His treatment course was a liver-directed treatment as well as combination immunotherapy and a VEGF inhibitor, and went through this treatment for 2 years. Our landscape of cancer treatment has drastically changed. The approval of targeted therapies and novel approaches to cancer treatment has changed this landscape of cancer treatment and survivorship. So understanding those patients that are treated with immunotherapy and how to care for them is really important from a multidisciplinary care and from a primary care provider standpoint. So management of these immune-related toxicity, this slide is not meant to talk about managing immune-related toxicities. Check out the other webinars. There are lectures on this. This is a multi-lecture talk in and of itself. But I wanted to point this out to you all, that immunotherapy, although very well tolerated, when somebody is on immunotherapy, they will appear like they're not on a cancer treatment like typically people associate with say chemotherapy side effects and the hair loss or, looking or feeling ill. People actually feel pretty well. But the risk or the challenge with immunotherapy is complications or these toxicities of autoimmune side effects. So from the image on your screen right now, immunotherapy can cause a side effect in any organ. So it's important to understand this, to be aware of that and understand if you have a patient on immunotherapy, understanding what their other comorbidities are and how to evaluate or work those up, or reach out to your subspecialty colleagues to help you sort through those. So I liked this image and this graph that I found through Cancer Research UK, talking about the key points for general practitioners as well as any provider across our healthcare system. So highlighting the importance of flagging those patients that are on immunotherapy. And I will tell you, there are many patients on immunotherapy that still refer to themselves as being on chemotherapy. And I have to correct them all the time because it's a critical difference. Again, the importance of interdisciplinary communication, of reviewing notes of, cancer providers, because sometimes you may have to look at those medicines and we remind patients that they're on immunotherapies, but I think chemotherapy is used as a broad term for many, many years, and it's hard to remember that sometimes for patients. So patients can present with nonspecific symptoms, so things like hepatitis, adrenal insufficiency, and one of the more common things I see in my patients is thyroid dysfunction. So we monitor thyroid function tests and may have to do a little touch of primary care in managing thyroid dysfunction, but sometimes they could be really challenging to manage, and referring to endocrinology. Sometimes we have to call on them to help manage these. Sometimes symptoms can present mild. Diarrhea, another common one, could be cough or upper respiratory infection. But it's really important to know if someone is on immunotherapy that it's not pneumonitis, that they could still get your general upper respiratory infection. So it's important to know and flag these patients. And the other thing to know is that we manage these immune-related side effects with steroids. So we don't want patients getting steroids for another reason, say for a severe respiratory infection or sometimes for uncontrolled back pain. Excuse me. Because we need to reserve steroids for those autoimmune complications that can happen. So understanding if your patient's on immunotherapy is really important. The other thing when we think about survivorship for those on immunotherapy is they could be on treatment for a year, 2 years, and then stop treatment. And they have no evidence of disease on their scans. And again, we go back to that curative intent, but it wasn't surgically removed. So another concept that is challenging for patients to understand, because then they, especially for my guy who had a recurrence, and then is going back to, those surveillance guidelines, and that landscape is evolving of how you follow those patients and, for how long they will be a part of your practice. This is a long-term survivorship. So again, highlighting how the definition of survivorship has evolved, and we can't just look at survivorship as those with who were treated with curative intent. So we will wrap up with this last bullet point of talking about health promotion and quality of life. So again, this is a conversation that I encourage all of you to have with your patients. Talking about healthy weight management. I think I hit home the role of regular physical activity, but also people's diets. I think it's important to educate. Many may know the importance of getting your fruits and vegetables and whole grains in. Many do not. And in the colorectal world, this can play a big role. So take the time to understand your patient's overall health. And those things outside of a cancer treatment that can improve their quality of life. And again, we can't talk about health promotion without commenting about avoiding tobacco and avoiding or limiting alcohol consumption. So here are some survivorship resources for your patients. There are so many out there. This is just to highlight that you can bring these up for your patients and help them to take ownership of their care, because a lot of those things we talked about are behavior change, which can be really challenging, and encouraging them to understand what resources are out there to help support them, to help them feel better. So we will shift a little bit, but still talking about survivorship. And again, hitting home this point about cancer survivorship is a very wide definition. So to transition this to caregivers. So what do you all think? How many cancer caregivers? These are unpaid, non-medical. So husband, wives, family members, loved ones, spouse, children, aunts, uncles, like you name it, even friends. I will give you all a minute. Oh, we're getting some variety. I like the variety. Then it makes me feel I didn't do totally all softball questions. So, yeah, these are big numbers. So no matter what the answer, I think it's still astounding numbers, right? But the actual number is 3 million. So I think many times the caregiver is not addressed as well as we can be doing when we think about cancer survivorship. So there's a lot of cancer caregivers out there, and they need resources and support also. So if they are caring for someone with cancer, they're a survivor also. So they need support in a wide variety of ways. So they have challenges being a cancer caregiver by things like watching out for treatment side effects, understanding what treatment they're on, being responsible for getting them to and from their appointments if someone needs assistance, even playing a role in treatment decision making and helping navigate that for patients so they're not doing it alone. Even down to at home, managing medications, what medicine to take for what, whether it's nausea, pain, diarrhea, the symptoms go on, and people have medicine cabinets at home. And many times caregivers are taking on that responsibility, and then they feel ownership of that. And when something doesn't go right, they blame themselves. So I think it's it's important for us to include them in these conversations. There's also life-changing effects, implications for jobs, whether it's the patient, if they were the primary caregiver, or the caregiver themselves, if they have to take FMLA, or depending on where that cancer journey is, whether they have to leave their job. So big life-altering things that are happening that caregivers need to be acknowledged and understand where they can have support also. So resources for that, the National Coalition for Cancer Survivorship, on their website, they have this Cancer Survival Toolbox program. It's a resource for caregivers. And there are short audio recordings that caregivers can listen to, and whether it's validating their feelings, whether it's tools or resources on helping manage some of these things. Caregivers are increasingly relied on for care, and there is more and more care that is happening in the outpatient or community-based settings rather than in tertiary centers or inpatient. So the role and reliability on caregivers has drastically increased through the years when a lot of our treatments are moving and have moved to the outpatient setting. So include your caregivers in the conversation, try to help and prepare them, discuss the skills and resources, not only for them to nurture their loved one, the one undergoing cancer treatment, but also themselves so that they have the strength and energy to continue to be a caregiver. So in summary, cancer survivorship has complex needs. We were only able to touch upon them. The evolving landscape of cancer treatments, approval of novel targeted therapies have changed the landscape of survivorship and the role of cancer care. Many patients are living longer, have multiple comorbidities, so aggressive chronic disease management and multidisciplinary care is really important for cancer survivorship plans. And some key strategies, talking with your patients, understanding those side effects and helping them manage. Refer to specialists when appropriate, including your cancer support services and mental health services, as well as promoting a healthy lifestyle. So thank you all for spending this hour with us. You can go to Poll Everywhere and input questions for us. We do have a couple of minutes. Here are our references. And we will spend the next couple of minutes answering questions before we leave for the afternoon. So Mary, while we wait for questions to come in, you started a testicular cancer survivorship program. So how did that happen for you? Maybe tips out there for those that may want to be starting a survivorship program in their area.
So I was voluntold to take over the testicular cancer survivorship program. It was initially started a year or two before I came to UNC by Dr. Paul Godley and Liz Sherwood, who was the nurse practitioner here when I came. And it was started with a grant from the Livestrong Foundation. And over the years have kind of tailored that program to kind of meet the needs of our team. So the typical cadence for incorporating these patients into my practice are I will usually see them after they've completed their treatment, whether that's surgery, radiation, chemotherapy, and are ready to start their surveillance. Usually they'll see their my physician partners for their first post-treatment surveillance scans and labs, and then they will get transitioned into my clinic. I do it imperfectly because I don't have the space that I used to have for it, but I can see these folks in any of my 4 clinics. And what we tend to focus on, and I think what's really important to focus on during survivorship visits, specifically post-treatment surveillance visits, are, of course, interpreting whatever diagnostics, which are going to be different depending on the cancer type, management of long-term side effects from treatment, and then the big bucket, the third bucket that I like to talk about with patients are their all the things we basically touched on today. So psychosocial things, health promotion. Do you have a primary care provider? Taking my name off their chart as their primary care provider, because no one wants me as their PCP. Thank goodness for our family medicine colleagues. My testis patients in particular have very unique post-treatment survivorship needs compared to, say, my older patients who have prostate cancer or bladder cancer. So making sure you're doing a good job of focusing those visits to the person who's sitting in front of you, because someone who's 24 who's gone through a cancer experience has very different unique needs than someone who's 67 and has gone through a cancer experience.
Great. So our first question, how does a patient with post-exertional malaise handle exercise? So, yeah, that's a tough one. So Mary, how do you discuss this with your patients?
Oh, that is tough. I wish that I had some sort of magic formula or magic pill to give people to help with these types of things. But I think a little bit of encouragement goes a long way. I think when patients hear, anything about having to exercise, and especially if they feel more tired after exercise, doing a gauge on what exactly are you doing. People might be pushing themselves too much, thinking that exercise means I have to, run a marathon. And I tell people, well, I don't run marathons, so I don't expect you to run a marathon. Making sure people are listening to their bodies with their physical activity. So if their bodies are saying, take a break, then take a break. And I think from our side of the street, if folks are coming in and specifically talking about this, making sure we're not missing some other underlying factor that could be contributing to this malaise that they're describing, such as anemia or thyroid disease or something else that is potentially treatable.
Yeah, I think I approach this in a similar way, understanding, this is a hard topic, and understanding other comorbidities, other things that may be playing a role, and understanding what activity are they trying to do, and for how long, and even just like I said, sometimes I tell people start with laps around the dining room table. Are they having post-exertional malaise with something like that? Then understanding what's happening from a cancer standpoint from another comorbidity or lab tests. So thank you for your question. And we will wrap up. So thank you all for joining us this afternoon. Thank you to the University Cancer Research Fund, to Lineberger Comprehensive Cancer Center and the Lineberger Cancer Network. To our amazing telehealth team, thank you to Tim, Benny, John, Oliver, Andrew, Patrick, and Barbara.